Welcome to the Skeptic's Guide to Emergency Medicine. Meet 'em, greet 'em, treat 'em, and street 'em. Today's date is June 30th, 2024, and I am your skeptical host, Ken Milne. The title of today's podcast is When I'm 64, Boom Boom, Old-Fashioned Doctors. Now you may hear some background noise. I'm currently in San Diego for an emergency medicine and acute care course. Just flying home today, in the airport, recording this. I had a fantastic time in San Diego. If you have never been to San Diego, I would suggest you check it out. Barb and I went to the zoo and had a wild time. So you may hear some background noise, some announcements and stuff like that while I'm doing this show, but I just wanted to get this podcast out and up for you to enjoy it this week. It is an SGEM Xtra episode, and it's from a presentation I gave at the Mayo Clinic. I was honored to be invited by Dr. Fernada Bellolio and my BFF Chris Carpenter to come to the Mayo Clinic last month and present to the Department of Emergency Medicine. They were kind enough to allow me to speak about any topic that I wanted to. I decided to talk about an article by Dr. Herbert Fred, published in 1998. And you can get a copy of my slides from that presentation on a link in the show notes. So the presentation started with asking the audience, when I say the term old-fashioned, what comes to mind? Think about it. Close your eyes, well, unless you're driving, but think about the term old-fashioned. What comes to mind? Is it old-fashioned technology, old-fashioned as in antiques, an old-fashioned drink, an old-fashioned Christmas? Maybe it's an old-fashioned fashion. Well, every generation of adults has been critical of the younger generation. And this goes back a very, very long time. There's a wonderful comedy sketch by Monty Python called Four Yorkshiremen. These successful old men talk about how hard it was when they were growing up. One man complains that, quote, he lived for 3 months in a paper bag in a septic tank. We used to have to get up at 6 in the morning, clean the paper bag, eat a crust of stale bread, go to work down the mill 14 hours a day, week in, week out, for 6 pence a week. And when we got home, our dad would thrash us to sleep with his belt. This prompts another man on the stage to say, luxury. If you've never seen the Monty Python skit, I suggest you check it out, and I'll put a link to the YouTube video in the show notes. There's also a 90-second video that illustrates that older generations have been crapping on younger generations for thousands of years. It's called The History of Adults Blaming the Younger Generations, and again, I'll put that link in the show notes. But now that we've discussed the general concept of being old-fashioned, let's talk about old-fashioned doctors specifically. There was an article published by Isaac and Fitzgerald in the BMJ back in 1999. It described 7 alternatives to evidence-based medicine. One of those alternatives that they were suggesting, with their tongue firmly in their cheek, was an old-fashioned doctor practicing eminence-based medicine. And they define this as, quote, the more senior the colleague, the eminent physician with that white hair and balding patch are called the halo effect. They place less importance on the need for anything as mundane as evidence. Experience, it seems, is worth any amount of evidence. These colleagues have a touching faith in clinical experience, which has been defined as making the same mistake with increasing confidence over an impressive number of years. Well, this brings us to the article that this lecture is based on. Dr. Herbert Fred wrote an opinion piece in the Journal of Hospital Practice in 1998. Dr. Fred was born in Waco, Texas, went to medical school at Johns Hopkins, did his internal medicine at the University of Utah, served in the U.S. Air Force, and then went on to teach for nearly 6 decades at Baylor College of Medicine and the University of Texas Health Science Center at Houston. In his article, Dr. Fred commiserates by saying, quote, In the 40 years that I have been a full-time medical educator, much has changed regarding what we teach and how we teach our students and house officers. As a consequence, I now confine myself to teaching basic medical principles that should never change. But even so, today's trainees tell me that what I say and do is old-fashioned. End of quote. Reading the article, it sounded like his students were directing a little bit of ageism towards him, and that his article was directing a little bit of ageism towards his students. And I get it. When you read the article, it can seem a little condescending and paternalistic, and certainly giving off a strong "okay, boomer" vibe. Well, after Dr. Fred makes a dozen complaints, he concludes with, quote, "If so, then I am proud to be old-fashioned, and I believe that if more doctors today practiced the old-fashioned way, our profession might regain some of the nobility and respect it once enjoyed." End of quote. Well, I posted this article on social media asking others if they considered themselves old-fashioned as defined by Dr. Fred. The vast majority of people responded with positive comments and emojis. However, some people pointed out another valid perspective about the condescending tone and the ageism expressed in the article by Dr. Fred. I wanted to go through 10 of his comments and show how these things are not necessarily old or new-fashioned, but rather timeless axioms of good medical practice. So we're going to go through those 10 things, because it's twice my favorite number of 5. So the first one was time with patient. Quote, "Is it because old-fashioned doctors spend whatever time it takes to obtain a good medical history and physical examination? Seriously, we would all probably like to spend more time with our patients. Back in the 1960s, the emergency room was literally a room. There was no specialty of emergency medicine back then. The physicians could take the time to sit at the bedside longer and focus on the one patient in the one room. Well, things have changed dramatically over the last 50 years, and it's now called an emergency department. And there's also current realities of metrics nudging or even forcing doctors to move faster and be more efficient and, quote, meet 'em, greet 'em, treat 'em, and street 'em. And then there's the dumpster fire of COVID-19 leading to the entire healthcare system seemingly signing out to the emergency department. We are expected to do primary care, post-op complications, mental health experts, substance use disorder specialists, etc., etc., etc. Wanting to spend more time with most patients is usually something we all want to do, whether you are a young or old doctor." The second point he made was about patient records. Quote, "Is it because old-fashioned doctors routinely seek all of the patient's previous medical records, not just the discharge summaries? Well, previous records were sometimes only on one index card for a general practitioner or a pediatrician. The addition of electronic health records has led to this huge increase in the length and redundancy of the medical record. It has been for a variety of reasons, including medical legal reasons and billing purposes. This problem has been coined the, quote, note bloat. And there are initiatives to try to address this problem. But how can you possibly find the signal in all the noise? Finding the information you need can be like trying to find a needle in a haystack. There are systems now being explored to use things like large language models and narrow artificial intelligence to find the relevant information clinicians need to make clinical decisions. In addition, EHRs have been identified by physicians as one of the top reasons for burnout. All right, the third point, sophisticated and expensive tests. Quote, "Is it because old-fashioned doctors do not order sophisticated, expensive studies when similar and cheaper procedures can supply the needed information?" Well, it's pretty easy not to order sophisticated and expensive tests when you don't have them. Who wants to go back to tasting urine to diagnose diabetes mellitus? Has anyone done a diagnostic peritoneal lavage lately? I mean, residents are using point-of-care ultrasound more and more, and they are really good at it. And of course, CT scanners are better than plain films for diagnosing head and neck and abdominal injuries. They can also find surgical abdomen pathologies missed on exam or even missed on ultrasound. Sure, we can be too quick to pull the trigger on the donut of truth, but diagnostic imaging has often improved our ability to diagnose people correctly. Number 4, brains and hearts. Quote, is it because old-fashioned doctors use their brains and their hearts, not an army of consultants to manage their patients? I think this comment really misses the mark. In 30 years of practice, I have seen wonderful, caring young physicians who don't rely on an army of consultants to manage their patients. And for the residents listening, have any of you worked with older physicians who were very unkind to a patient and seemed to consult on every patient? I don't think brains and hearts have anything to do with age, but rather with individual practice style and personality types. Number 5, treat patients, not numbers. Quote, is it because old-fashioned doctors treat patients, not numbers? I agree that we should be treating patients, not numbers. Treat the patient as a person, not as a statistic. However, did old-fashioned doctors always treat patients as people? If I'm looking at U.S. history, because I'm presenting at the Mayo Clinic, the 14th Amendment, this is when black people were finally recognized not as property, and that was in 1868. Yet 150 years later, we still see racial disparities in the House of Medicine. There continues to be racial bias with multiple lines of evidence to support this claim. And then there's the 19th Amendment. Women got the right to vote in 1920. Yet 100 years later, female patients are still treated differently at times in the House of Medicine. Hysteria or hysterical was used to describe a neurotic condition in people, women, with uteruses. And then we can go to 1973, and the American Psychiatric Association removed the diagnosis of homosexuality from the second edition of its Diagnostic and Statistic Manual. There was a lot of stigma around gay male patients, especially in the late 80s and early 90s during the height of the HIV/AIDS epidemic. Were these men treated as patients and not numbers? And now, in the 2020s, we have trans and non-binary people fighting against discrimination. I would advocate that physicians treat every patient as a person with kindness, no matter what size, shape, color, or how they identify. This has nothing to do with being an old physician or a young physician. All right, we're halfway through. Let's do the second 5. So this is number 6, a pill for every ill. Quote, is it because old-fashioned doctors do not blindly administer a ton of drugs in an attempt to alleviate every possible ill? This is another case of it being easy not to treat patients with lots of drugs when we had few defined diseases in the past and very few effective medical therapy. In 1899, Bayer aspirin was patented. However, the medicinal properties of salicylic acid go back to 4000 BCE. Over the last 100 years, we have had several wonder drugs that can prevent illnesses and save lives. Sure, some patients deny any medical history and then bring out all these medications that they're currently on. But if you had a heart attack in the past, you would get an aspirin, some morphine, some nitroglycerin. But now you'll also probably get dual antiplatelet therapy, an angiotensin-converting enzyme inhibitor, a beta blocker, a statin. These have been shown to improve the outcomes after suffering a STEMI. And yes, there is over-testing, over-diagnosing, and over-treatment, but some pretty amazing drugs have come along that can save lives. We've got vaccines, antibiotics, diabetic drugs, antipsychotics, the birth control pill, asthma drugs, and others. Modern medicine has contributed to the dramatic increase in life expectancy. All All right, the seventh point is, quote, is it because old-fashioned doctors recognize that doing nothing at times is doing a lot? Intervention bias has existed forever. It's part of human psychology, and it's not unique to young doctors or old doctors. As an example, George Washington died in 1799 at the age of 67 after suffering from a fever, lethargy, sore throat, and difficulty swallowing and breathing. The old-fashioned doctors at the time did bloodletting and removed about 40% of his blood volume. Bloodletting was the standard of care. In addition, George Washington gargled with molasses, vinegar and butter, he inhaled steam of vinegar and hot water, and his throat was also swabbed with the preparations of dried beetles. It is possible he may have survived if his physicians had just stood there and skipped all of these things and just did a tracheotomy. Another example of intervention bias from the past involves another president named George. George W. Bush was considered a very physically fit and active man at age 67. They identified asymptomatic coronary artery disease at an annual physical examination. As a result of the physical, physicians put a stent in his coronary artery despite the lack of evidence of benefit compared with initial medical therapy for the prevention of death, non-fatal myocardial infarctions, and unplanned revascularizations or angina. Intervention bias is not an old-fashioned doctor problem, but rather a human psychology problem that biases people into doing something rather than inaction. I've learned a lot from my mentor, Dr. Jerry Hoffman, to be on guard for this intervention bias. He taught me to do things that have good evidence to demonstrate a patient-oriented outcome of benefit. Without such sufficient evidence, his advice was, don't just do something, stand there. All right, number 8. Quote, is it because old-fashioned doctors understand that patients often get well despite what we do, not as a result of what we do? Well, I've seen old-fashioned doctors claim somebody got better because of what they did. This can be a logical fallacy, specifically post hoc ergo propter hoc, or after this, therefore because of this. Think of giving people ketorolac for renal colic. Shortly after administering this non-steroidal anti-inflammatory, the pain subsides. Is that because the treatment worked, or is it because the natural history of colic? I've seen both young and old physicians commit this logical fallacy, when the intellectually honest answer would be, I don't know if the improvement was caused by our action. And just if people are interested in these types of logical fallacies, the first known systematic study of fallacies was done by Aristotle, and he listed 13 types of fallacies, and I'll put those in the show notes. The 9th point was about kindness. Quote, is it because old-fashioned doctors realize that good rapport with their patients is the best protection against lawsuits? This point really speaks to me about kindness. We should be kind to all our patients, staff, and ourselves. If one of the secondary things is less likely to be sued, then fine. But this should not be the primary reason to have a good rapport with patients. We often know so little about our patients' lives and their experiences. Many are fighting hard battles we know nothing about. I do like a quote from Aldous Huxley, who said, quote, it's a little embarrassing that after 45 years of research and study, the best advice I can give to people is to be a little kinder to each other. Well, this is not old or new-fashioned. This is just an axiom, a truism, a little timeless piece of advice that we should all be kinder to each other. All right, the 10th and final one is, I don't know. Quote, is it because old-fashioned doctors are aware of their own fallibility and are never afraid to say, I don't know? Well, maybe it is safe for a senior physician to say, I don't know, because they have a certain amount of status and privilege. But this is different than a resident acknowledging a knowledge gap or their fallibility. We as attending physicians need to create an environment where it is okay to say, I don't know. and it's our job to help residents find the fallibility. It's an unrealistic expectation for learners to get every question right. Medical knowledge has expanded so much since we were going through our training as older physicians. New physicians can't possibly memorize everything. We should focus more on teaching residents how to think critically rather than what to think. Give them the critical appraisal tools to evaluate the evidence. Make a safe space for them to be wrong and explore their knowledge gaps. There are some great quotes from the physicist Richard Feynman, but one of my favorites is, "We need to teach how doubt is not to be feared, but welcomed. It's okay to say, 'I don't know.'" So those are the 10 points that I wanted to pull out from Dr. Fred's article from 1998. At the end of the day, it's not about being an old-fashioned or new-fashioned doctor. It's more about being on what I like to call team patient. It starts with patient care and it ends with patient care. And our decisions should be centered about what is in the best interest of patients. And some of these things are timeless. Providing patients with the best care based on the best evidence with kindness. All right, that ends the SGEM Xtra episode while recording in the San Diego airport. Hopefully it wasn't too noisy for you. The SGEM will be back next episode doing a structured critical appraisal of a recent publication, trying to cut that knowledge translation window down from over 10 years to less than 1 year, using the power of social media, so patients get the best care based on the best evidence. And remember to be skeptical of anything you learn, even if you heard it on the Skeptic's Guide to Emergency Medicine.